And they can have that infectious transfer from really anything. So it can go across the placenta, it can go through the cervix, it can happen during delivery. And one of the things to really note is the difference between term infants who are still at risk for sepsis, and those preterm infants. So 1 in 1,500 versus 1 in 250 is like a 6-fold increase. And I will pause here to say, anytime I'm giving you an epidemiologic number like this, no way would I waste a test question on how many term infants get sepsis, right? That's a stupid test question. All I'm trying to do is give you context for how common and risk stratifying, okay? So please don't spend time memorizing epidemiology like that, but just be aware of the conceptually. So the concept to pull from this is preterm infants are at significantly higher risk of sepsis than term infants, okay? Why is that? Well, number one, their whole immunological structures and their defenses are not fully mature yet. They haven't gotten all the maternal antibodies, and they're likely going to be in the hospital for a long time. And if there's one thing healthcare workers are great at, it is giving infectious processes to people. So we don't need to, we try not to. Another risk factor we talked about yesterday is those prolonged rupture of membranes, or PROM, more than 24 hours after that clock has struck. So that's why we care so much about that time of rupture, that rupture of membranes. If mom had group B strep, so you'll learn in women's health and OB that they will check mom for that bacteria because that is going to be one of the #1 causes of neonatal sepsis. And then was there something else going on during delivery? Did mom have a fever? Was there clear infection in the placenta, in the amniotic fluid that made it more likely that the baby is going to develop this? Or during delivery, did the baby have increased signs of stress? So fetal tachycardia, if you guys are in your OB rotations, you're working in OB, when the baby is having persistent fetal tachycardia, they can't tell you, hey, I don't feel good, it's not going well in here, and so the only thing they can do is show you an increased heart rate. So it's a sign of stress. Again, most common reasons that an infant, or most common infectious etiologies, and the reason that this matters, you're like, why are we going early sepsis or late sepsis? So in that first week of life or after. The reason this clinically matters is because it's going to change what your coverage is. So some infants you're going to give this antibiotic coverage versus that antibiotic coverage based on what that most likely etiology is going to be. So in that first week of life, you think they just came out, I think it's got to be group B strep from mom and from delivery. Or they were mixed up in that whole perineal area as an E. coli sepsis, and then the list goes down from that. Versus they are a little bit older and you start worrying about H. influenza or skin infection, Staphylococcus aureus. Is it a viral infection, HSV? So your risk stratification changes at that point. A little bit is their clinical presentation as well. So if it's in that first week of life, typically it is a very fast onset. So the baby was fine, 2 hours later they are not fine. That's what I mean when I say fast, within a matter of hours. So they could be febrile, so they could have a temperature of greater than 38 degrees Celsius. We have a whole lecture on fevers. We'll talk about that at some point. Or they could be hypothermic. Remember we talked yesterday, infants don't hold temperature very well. And so if they are using all of their energy to try to maintain their temperature and they cannot, that is another sign that they are pretty ill. So hypothermia can be just as dangerous in a baby as hyperthermia. Hypotonia, they're limp babies. A totally limp baby is a sick baby. And then hypotension, certainly if you're getting a blood pressure. This is where I will, my second foot stomp, just in general, is vital signs. They are called vital signs because they are vital. They're not called optional signs, right? So they are giving you a lot of information. So a low temperature or a low blood pressure is just as concerning as something that is high. Right? So your vital signs are quite vital. This is different than late onset. So late onset might be significantly longer, more hours, or even days. They just haven't been themselves over the last 24 hours. Versus in the last 2 hours, they've gone limp, something like that. This could be seen in all kinds of things. So temperature, any of the same stuff, or they could just be truly lethargic, meaning they are not able to be aroused. So when people typically say lethargic, what they mean in the lay people terms is they're a little tired and they're just watching TV and they don't want to play as much. True lethargy now, provider to provider, means they're unable to be aroused and then you need to do a sternal rub. Almost untended. Right? That is lethargy. That fontanelle can be bulging. Again, they can be hypotonic or hypertonic, seizure-like things, and then we'll talk about bilirubin as we go along here. And these infections, though they be more insidious in their onset, they can have significantly more associations with other systemic infections. So is this in the brain? Is this in the bones? Is this in the bladder? It can be other places that you see. Your evaluation for these babies is going to look at, number one, a CBC. So you're doing a complete blood count to say, where are the white cells? Are the white cells high? Are they low? Do they have the right number of cells? You're going to get blood cultures from 2 different sites. So whenever you get blood cultures, you're getting them from 2 different places to make sure that you're getting a good sample. You're getting a urine culture, a urine analysis with culture. So for the rest of your time, you need to put together urinalysis and urine culture for a child. Those have to go together because it's not like adults who concentrate their urine and then you're like, can you please give me a sample? And they're able to give you a sample. Babies just pee on demand, and so they don't have that time to concentrate the urine and allow the bacteria to replicate. So you have to get the culture. So you get the urinalysis and the culture in kids every time. Marry those up. So if you're working in an ER or an urgent care, do not just get the UA and call it good. Always grab a culture. Okay? So this is part of that. Urinalysis with culture, and then you're checking their complete metabolic panel, which will contain the glucose. Make sure they're not hypoglycemic. Depending on how old they are, we'll talk about those specifics, but depending on how old they are, you're worried about where is the infection. So you've already checked the blood, already checked the urine, and now you have to worry about, is it in their CSF? We have that leaky blood-brain barrier, we have vascular permeability, so is it gotten into their CSF? So a lumbar puncture is part of this, and all of those same things. You're getting how many cells are in your CSF? How much glucose? How much protein? Does it have any bacteria? There's a culture. So all of those same tests now are in your CSF. There is no standard imaging though. So this is one that will trip people up often because they're like, well, I'm just going to get a chest x-ray. I'm just going to get an ultrasound. What do you ultrasound? And they're like, I don't know, but you told me to get an ultrasound. I'm going to get an ultrasound. And you're like, cool. I love the effort. But there's no standard imaging for a neonatal sepsis workup. You're more worried that there's some fluid that's infected somewhere. So the only time you would get imaging, particularly chest x-rays, is if there are some sort of respiratory symptoms. So certainly if you have a cough, if you have respiratory distress, get a chest x-ray. But if there's nothing in real life in this baby, and there's nothing in the question stem that has any kind of respiratory, then don't get a chest x-ray. Don't just ultrasound things where you don't know what you're ultrasounding. Again, love the effort, but don't just ultrasound things. So what are you going to do for this baby then? Well, this baby doesn't get to go home. This is not one that you get to say, hey, we're just going to do a sepsis evaluation and send you out the door. So they are going to stay in the hospital. They get an IV. They are getting fluids with glucose to make sure their glucose stays high. And you are providing nutrition for them. And then they are getting IV antibiotics started as soon as possible. This is where that coverage will matter. So if you are under 3 weeks old, you are going to get IV ampicillin, which is functionally amoxicillin, or IV penicillin, and gentamicin. So amp and gent, you'll hear that a lot. Give them amp and gent, amp and gent, amp and gent. If you are over 3 weeks old, you are going to get ampicillin and cefotaxime. And that is because up until the age of 3 weeks or so, you don't have the ability to metabolize the cefotaxime. So your gallbladder and your liver function is not there to be able to handle cefotax. Okay, so you want to give them gentamicin that has the coverage, but it's ototoxic, so you don't want to, well, I can't metabolize it, and it might hurt the ears, so I have to start with gentamicin. Now that I'm 3 weeks old, I'm going over to cefotaxime. It's not ototoxic now that my liver is up and functioning. If you think that there is later onset, so you're thinking, ooh, I remember that column, it had staph as one of the things to worry about several weeks later, maybe I should add vancomycin. Right? So unless you're worried about MRSA, you're really not adding that. But if you see something or some family tells you, yeah, I don't know what's going on with this baby, but we've all had MRSA infections all the time, and now you have a baby that looks septic, I would sure add vanc to that one. And then if there you think, you even sniff out that there was any kind of herpes, you add acyclovir, because that is a devastating diagnosis to a baby. So anytime HSV is on your differential, add acyclovir because you can always take it away. Things that you will look at. So if you have a negative culture in a clinically well baby after 48 hours, so the first 24 will likely show you growth on a plate of all your cultures. Second 24, nothing's grown. 48-hour rule out is what we'll call it. If you have the negative and the baby is clinically well, you get to go home at 48 hours. If something pops positive, then you do not get to do that. And again, that will be what popped positive. Was it in the blood? Was it urine? Because those are different days of management than if it was in the CSF. So CSF is going to have much longer treatment and has a 3-week treatment compared to your other fluids that don't need as much and as higher dose. And so those are only for 10 to 14 days. So the what fluid was positive matters. I don't need you guys to know this particularly, but just to be aware of it, that as you're going along and you do your maternal history, or you see a patient who looks septic and you go back to say, was mom positive for group B strep? There are apps and there are algorithms that will go out to say, okay, mom was positive, did they get screened? Did they have a sepsis evaluation? Are they clinically well? If this, then that, to be able to follow those protocols for what those recommendations are. So just to know, GBS is still a pretty big deal out there. We do a whole lot of screening specifically for that. Okay, so that was neonatal sepsis. Let's talk about when we have true respiratory distress for a child. So again, this is going to matter if you are term versus preterm. Both of them can see sepsis, both of them can see pneumonias, but you start seeing respiratory distress syndrome in preterm infants, and you don't see that as much in these term infants. You start seeing things like meconium aspiration syndrome. Anyone know what meconium is? It was, yeah, your initial baby poop, right? So we'll talk about that. Both of them can see congenital heart disease, both of them pneumothorax. So the biggest difference is respiratory distress syndrome for preterm and meconium aspiration for postterm, or for term. Those are the big ones. Of note, if you've never seen a baby, one of the things that they will do in a sign of respiratory distress that might not be recognized right away is if a nurse or an LPN or a med tech or another doc or a PA or whoever comes up and says, I think the baby's grunting. So what grunting is a clinical sign where the baby literally sounds like they're grunting. So you're welcome for this. It'll say, it's like they're literally grunting. And what they're trying to do is they're trying to keep open their alveoli by increasing that pressure. So they're trying to do their auto, meaning themselves, positive end expiratory pressure, auto PEEP, where they're trying to hold open those alveoli. That's a sign that they're in distress. So that would be one that baby looks kind of fine, but they're grunting. If someone tells you that clinically, get up and go evaluate that baby, because that's an early sign of respiratory distress. It's different than respiratory distress syndrome. So again, notate this as premature infants. So that's who this goes with. Remember, this was the reason Highland membrane disease is what it used to be called, what JFK's child died from. Super interesting story. That child would have lived very easily now. But. So in utero, those type 2 pneumocytes that make the surfactant that we talked about yesterday, if you don't have that, now your surface tension, it's like a balloon that is collapsing with each breath. Usually in those preterm infants before 34 weeks. Do we have them or not? What do you remember, does anyone know what we give mom to try to trick those type 2 pneumocytes?
Steroids.
Yeah, steroids. So that's the trick, is that we will trick the baby's type 2 pneumocytes into making surfactant is to give mom steroids early. And the pneumocytes then, it triggers the the signals to say, oh, I guess I should make surfactant. And so that is one of the things that we will do. On x-ray, when you see this, the chest x-ray read will look like ground glass. So if you think about what glass would look like if you just ground it up and then you took a picture of it, that's what it looks like on chest x-ray. So it just looks hazy, fuzzy, looks ground glass-like is the best way to put it. So if you're looking at this, this would be often what the chest x-ray would look like. What else do you see besides ground glass in this chest x-ray? Air bronchogram, cool. What else? If you're looking at lines and tubes, that would tell you, yeah, this big as an NG tube and this baby is intubated, right? So it's going to tell you a lot. So if you just see a picture in an exam type question or in a clinical scenario, you can get a lot from the baby's status by looking at the rest of the x-ray, not just the lung fields. So if one of the answers is home management, and that's the picture that it goes with, it's not the right answer, right? Because they have an ET tube in place. You guys already said it, maternal steroids prior to birth are going to be important. Let's say you're born, came in no prenatal care, precipitous delivery, baby just came, they're 30 weeks old. You intubate that baby and you can actually give surfactant through the ET tube. So what was the other medication that we could give yesterday? Through the ET tube? Yeah, epinephrine. Yep, so we can give epinephrine as one medication. We can give surfactant, endogenous surfactant as the other one. Things that can happen though, if you have this hyaline membrane disease or respiratory distress syndrome or surfactant deficiency, is now you are more likely to have barotrauma and a secondary pneumothorax. You can have some pulmonary, bronchopulmonary dysplasia if you are significantly preterm. Also retinopathy of prematurity if we're having to give high levels of oxygen as a compensatory mechanism for the prematurity. So just some of those other secondary things to think about. Apnea of prematurity. So the definition we talked yesterday, a neonatal's response to hypoxia is apnea. But we didn't really define what apnea is. So apnea is the absence of a breath for 10 to 20 seconds. So 20 seconds is a long time to wait in an infant who is breathing every 1 to 2 seconds. And so that's a long time. If you're like watching this baby breathe and you're like, oh my God, they're not breathing. So that can be a long time. It can be a couple of reasons. One is their brain actually telling them to breathe. So it would be a central apnea. Two is an obstructive apnea, so something in the way, a mucus plug, something else is going on. Are they not positioned right and all kinked there? Or is it mixed? Are they so premature that they're not getting the signal all the time and they're all kind of slumped down in there? Oxygen treats that, so oxygen helps prevent the hypoxia that helps prevent the apnea. So that's the treatment. However, you are still worried that you aren't seeing, that you don't want those oxygen levels too high. So always that balance to think about. The other thing that we really do give babies are stimulants. So babies will get IV caffeine to remind them to breathe. So that is one of those treatments that you will give in the NICU. And most of the time, by the time they reach a term age, so if they were premature, by the time they reach something where they would have been born normally and gone home right away in that 36+ week mark, they're usually at that point remembering to breathe enough and able to hold their head in a position that they don't have the obstructive or the mixed type. Another entity that is specific to these young guys is a tracheomalacia. So trachea meaning the trachea, and then the malacia meaning kind of the softening. So if you feel your trachea and you are feeling it, it shouldn't be able to just press in, it should be able to fold in on itself. The baby's trachea is very soft, and as they breathe in, or as they're crying, and they breathe in, you can often see it kind of fold in on itself. And that creates a very large, harsh, stridorous sound. So they will be You can see it sometimes collapse in, and then while they're trying to breathe out, it is still collapsed, and so you are hearing that sound. So you can see it worse if they're crying because there's more air movement, worse if they're coughing, worse if they have a URI because they're doing both of those things, and then sometimes even with feeding. So it's kind of a floppy trachea is a way to think about this. If it's mild to moderate and they're still gaining weight, no respiratory distress, it just is a freaky sound to everybody, you can watch that. If it is severe cases where they do have hypoxia, there's some feeding difficulties going on, that is when they will need an ear, nose, and throat or otolaryngology eval, because potentially they will need something to stent that airway open. So back to meconium aspiration. This is a little bit like respiratory distress syndrome of a term infant. And the reason I say that is because in respiratory distress syndrome, they didn't have surfactant. Well, baby poop, that meconium, that first baby poop, will also denature the surfactant. So if the baby has swallowed this, or inhaled it really, and the baby meconium has gone down into the airways, will denature the surfactant, so you're functionally in the same exact position that you were before, where you didn't make it, because now you had it, but it is non-functional. So this is functionally like term baby RDS. It's kind of the way to think about it. But these term babies don't have surfactant either, but for a very different reason. And so that is why every single time that if they're doing a rupture of membranes and there's meconium noted, that is why PEDS team is ready at delivery, because you are worried that there has been an inhalation of the meconium and they're going to come out in respiratory distress. Same things are going to apply that respiratory distress did. So that barotrauma can cause a pneumothorax with resuscitation, can have increase in pneumonias from the pneumonitis, from the inflammatory process of having poop in your lungs. And one of the things to think about while you're resuscitating is to try to get out as much of the meconium as possible so they don't inhale it. So most of the time they'll come out kicking, screaming, with poop all over them. You treat that just as a normal resuscitation, but making sure if they are non-vigorous and you have a floppy baby that comes out, you do a good suction to get out all of that meconium. Looks a little bit different than that ground glass appearance, because the ground glass appearance, because of the prematurity, it means all the alveoli are affected, versus these coarse and patchy spots just where the meconium is inhaled. So that's a little bit of the difference that you see. So number one, a hint for test questions. If you see them being premature, that's a good hint. If you see the differences, if it's everywhere in the lungs versus just part of the lungs, that's another hint of which one am I dealing with there. Treatment, again, supportive care, surfactant if necessary, and then ventilation if they need it, depending on how significant it is. And sometimes these babies will even end up on ECMO to give their lungs a complete break while they heal. Transient tachypnea of the newborn. So you're going last one that we will do. So this one, you have to be transient, you have to be tachypnic, and it has to be a newborn. You need those three parts. So in this, if you had a really fast delivery, if you think about what delivery is doing, delivery is functionally wringing out the baby. So the lungs are getting wrung out from all the amniotic fluid. So if you don't have time to do that, and you come out the chute, or you're a C-section, where we just cut you open and yank you out, all of a sudden you have kind of these wet lungs that didn't get the signals to kind of wring out the lungs to be prepared to breathe. So you come out and you are trying to breathe really fast to get rid of all of that excess fluid that is in the fissures between the lungs. And so thus you see newborns that have tachypnea and that it is transitory. So over the course of the next day or two, the tachypnea resolves. But right when they're born, they have this tachypnea trying to get excess fluid out. So common in C-sections, common in big babies, common when there's really fast deliveries. They have some respiratory distress, but not severe. And you see on chest x-ray that excess fluid between the fissures. And that's a good place to stop. I know you guys have to get going. So we will pick up with neonatal anemia on Thursday. Questions, comments, concerns, anxieties,